All right, so we'll go ahead and get started. Good morning, everybody. There actually are people in the room, and there's always coffee. So people want to come. We welcome folks to come to Clinical Sciences Building. Welcome to our hybrid medical grand rounds. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So it is my absolute delight to introduce Dr. Miles Marchand, who's coming to us from the almost melted snow Vancouver area. Miles is a fifth-year cardiology resident from UBC. He grew up in Kamloops and is a member of the Okanagan Indian Band, whose traditional territory is near Vernon, BC. After studying physiology at McGill University, Miles completed his medical school at UBC, and he then completed his internal medicine residency at UBC, where he was the chief medical resident. Dr. Marchand has a strong interest in Indigenous cardiovascular health, particularly with regards to primary and secondary prevention of cardiovascular disease and congestive heart failure. And I had the opportunity to hear him speak, and I thought that it would really benefit us all to hear the perspective that he brings. So he's going to be speaking on the topic of Indigenous heart health perspectives of a First Nations cardiology fellow. So I'll hand it over to Miles.
For the introduction, and thanks for inviting me. I'm really excited to be here today to speak with everyone about my perspectives on Indigenous cardiovascular health as a First Nations cardiology fellow. So I'd also like to just respectfully acknowledge that I'm a humble guest on the unceded traditional homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. These are my disclosures. Now, I'd like to start with this picture. This is a photo of the Kamloops Indian Residential School where my granddad went to school in the 1940s. And attending this school was his only chance to obtain an education. But with that, he was taken from his family, his culture, and his home on our reserve. I'd like to take a moment of silence to honor the 215 children whose unmarked graves were discovered here in 2021, as well as those of Indigenous children across the country. Now, this is a photo of St. Paul's Hospital in downtown Vancouver, where I work now. See the resemblance? Imagine how a residential school survivor might feel if they required care here. Think about how triggering it might be for a First Nations patient to be shipped from their home in a plane to arrive at this building. Without family, without their culture, it can be a terrifying experience. And earlier this year, I was on a plane to Hamilton, and I was talking to the man next to me. I explained that I was a First Nations cardiology fellow traveling to Six Nations to discuss heart failure as a healthcare priority in the community. And his response was that he didn't respect Natives, that we are thieves, and that we just wanted what he called freebies. So this just reminded me of how much racism still exists in Canada and how much work there is left to do. And that type of racism extends into the healthcare system. This is a photo of Joyce Echequan, a 37-year-old First Nations mother of 7 from Quebec. She had a history of cardiomyopathy with a previous pacemaker insertion. She presented to hospital with abdominal pain, and during her stay, she was ridiculed by medical staff. They told her that she made bad choices, was only good for sex, and was stupid as hell. Joyce captured these remarks on video. She was given sedating medications and was later found dead in her hospital bed. Her autopsy reported that her death was accidental and her cause of death was pulmonary edema. And I think we can all agree that it's pretty unusual for a 37-year-old woman to die of pulmonary edema, let alone while in a hospital, which many people identify as a safe place. And I would argue that she might still be alive today if she was not Indigenous. I also want to touch on the In Plain Sight report. This was a large-scale investigation performed in BC in 2020 to address Indigenous-specific racism and discrimination in our healthcare system. The review was performed in response to allegations of healthcare workers playing a Price is Right game to guess the blood alcohol levels of Indigenous patients in the emergency department. And some of the key findings from the report that stand out to me include widespread Indigenous specific stereotyping, racism, and discrimination exist in the healthcare system. Racism limits access to medical treatment and negatively affects the health and wellness of Indigenous peoples. Indigenous healthcare workers face racism and discrimination in their work environment. Current education and training programs are inadequate to address Indigenous specific racism in healthcare. Indigenous health practices and knowledge are not integrated into the healthcare system in a meaningful and consistent way. Indigenous roles in health leadership and decision-making need to be strengthened. And there's no accountability for eliminating racism in the healthcare system, including system-wide data, quality improvement and assurance, and monitoring of progress. And while I think it's important to acknowledge the systemic racism and intergenerational trauma faced by our people, I think it's equally important to recognize our strength and resilience. This is a photo of my grandfather, Len Marchand. He was born on our reserve outside Vernon, BC, and lived in a 600 square foot home with 8 brothers and sisters. He attended the Kamloops Indian Residential School, and when he finished there in grade 8, he fought for the chance to attend a public high school, where he was only allowed to enter into the trade stream. And after some forward-thinking teachers recognized that he was actually a pretty smart guy, he was allowed to take some academic courses. He went on to be one of the first Indigenous people to attend UBC, where he attained a Bachelor in Agriculture and later a Master's in Science. And he eventually became the first status Indian Member of Parliament, where he fought for rights of Indigenous peoples and served as the Minister of Environment. This is one story of Indigenous triumph that's close to me, but there are countless other stories like this. And I think these are stories we must continue to recognize and celebrate. His resilience is my source of strength, and I don't know if I'd be where I am today without his passion and determination. So my objectives for today's talk are to review important definitions pertaining to Indigenous peoples, to recognize upstream risk factors for the development of cardiovascular disease in Indigenous people, to review disparities in cardiac care between Indigenous and non-Indigenous people, and to outline strategies to engage Indigenous patients and communities. So I'd like to start with a few definitions. The etymology of the term Indigenous means sprung from the land or native. It's an overarching term to include all of Canada's First Peoples, including First Nations, Métis, and Inuit peoples of Canada. It's a globally recognized term used by the United Nations to recognize and empower Indigenous peoples worldwide who have distinct cultures but share similar colonial histories. And it's come to replace the word Aboriginal, which is a term that was introduced by the Canadian government in the 1980s. And if you think about the etymology, Aboriginal can actually be interpreted as not original, similar to how abnormal means not normal. Inuit means the people in Inuktitut, and the Inuit are Indigenous peoples whose traditional territories lie in Canada's Arctic and subarctic regions, and there are also ethnically Inuit people living in Alaska and Greenland as well. They're a highly resilient and resourceful people, and their traditional lifestyle has adapted to the extreme climate conditions of the North and relies heavily on fishing and trapping. The Métis are a distinct cultural group with unique traditions, language, and nationhood. And they emerged from the offspring of First Nations women and European fur traders in the Red River Valley and historic Northwest during the 18th century. First Nations people are Indigenous peoples descending from or belonging to one of more than 50 distinct nations that existed prior to Canada's colonization and continue to exist today. So this includes both status Indians as defined under the Indian Act, as well as non-status individuals. And whenever possible, people should be recognized by their distinct nation or band, as this is a more specific identifier which more accurately reflects a First Nations person's culture and background. I also wanted to point out terms that should not generally be used. So the term Indian originates from European colonizers who believed they had arrived in India. So that's clearly inaccurate, and the word Indian is a derogatory term when used to describe an Indigenous person. The term is still used by the federal government for historical reasons as a result of the Indian Act, which was passed in 1876. So this is where the term status Indian comes from, as defined under the Indian Act. But outside of its use legally within the federal government, the term should not be used. The term native has also fallen out of favor and has developed a derogatory connotation. Native American is a term to describe Indigenous Americans and is an inaccurate way to describe Indigenous peoples in Canada. And the term Aboriginal has been largely replaced by Indigenous, as I have already described. I also wanted to highlight that it's not just the words you say, but the way you say it that also matters. For example, this identifying statement, a 55-year-old First Nations man with alcohol use disorder presenting with new heart failure, presumed related to alcoholic cardiomyopathy. While none of these words in and of themselves are offensive, the close association of First Nations and substance use in almost this reflexive way perpetuates negative stereotypes. And I've heard well-meaning people present cases like this over and over again, but it's so important to understand the implications of the way we say things and how this can perpetuate implicit bias in our practice. Now, I'm not suggesting that we leave out relevant information when talking about First Nations patients out of political correctness, but try something more like this. A 55-year-old man from the ex-First Nation presenting with new shortness of breath, orthopnea, and PND with clinical evidence of heart failure. He's been transferred from X community. His past medical history includes hypertension, dyslipidemia, and alcohol use disorder. The differential diagnosis includes ischemic and non-ischemic causes. So I presented the same information here, but have not so closely associated the words First Nations with substance use, which can be so stigmatizing. I also wanted to provide definitions for cultural humility and cultural safety. So cultural humility is recognizing that you cannot be competent in another person's culture or fully understand what it's like to walk in their shoes. We used to talk about cultural competence, but it does not really make sense for a person of one culture to be competent in another. But using cultural humility, we make time to listen and to learn without making assumptions about another person's culture and experiences. And it begins with an in-depth examination of a provider's assumptions, beliefs, and privilege embedded in their own understanding. And it allows for Indigenous voices to be front and center and promotes relationships based on respect, open and effective dialogue, and mutual decision-making. Now, cultural safety is a similar concept, but has some important differences. First, it can only be defined by the Indigenous person receiving care. It's experienced as respectful and safe and allows for meaningful communication and service. It includes physical, social, emotional, and spiritual safety. Cultural safety is without challenge, ignorance, or denial of an individual's identity. It's without profiling or discrimination, and it requires positive anti-racism approaches and the continuous practice of cultural humility. And finally, reconciliation, which is an ongoing process through which Indigenous peoples and non-Indigenous peoples work cooperatively to establish and maintain a mutually respectful framework for living together with a view of fostering strong, healthy, and sustainable Indigenous nations within a strong Canada. And it requires that we acknowledge the wrongs of the past, and I would argue the wrongs of the present as well, to know our true history and to work together to implement Indigenous rights. And as clinicians, we must work to reconcile wrongs of the past and present by listening to and respecting our patients and their experiences and committing to improving care and outcomes for our Indigenous patients. So now let's talk about Indigenous heart health. First, I think it's important to recognize that for some Indigenous peoples, the heart is more than just the cardiovascular system. It has cultural significance that goes beyond a biomedical worldview of health. For Esther Sanderson, a Cree elder, she feels that the heart is where the blood that flows through our body carries our ancestral knowledge, ceremonies, and songs. It's the same blood flowing that makes me who I am today. So the heart for her is more than just an organ, but it's actually the very essence of her being. Mary Wilson, a Cree wisdom keeper, has wondered, how many times were parents' hearts broken when the children were taken away to go to residential school? The lasting effects of intergenerational trauma have not only affected Indigenous people's cardiovascular health, but it goes so far beyond that. When beginning an interaction with Indigenous patients, there's one key question that I think we should all use, and it's quite simple. Where are you from? Now, some people feel uncomfortable asking this question as it can make people of color feel othered when asked in the wrong context. So it's something to be aware of. And other ways of asking this question, if you do feel uncomfortable, might include, tell me about your home, or tell me about where you grew up. And for many Indigenous people, this serves as an invitation to not only share where they come from, but also who their families are, what nation they belong to, and who they are as people. This can help establish therapeutic relationships, and each nation has distinct contextual, cultural, historical, genetic, and geographic factors that contribute to their health and wellness. And taking the time to understand this context allows us to connect with our patients to provide safe and humble care based on mutual respect. As an example of the distinct health differences between nations, I'd like to touch on the long QT syndrome in the Gitxsan First Nation in northern BC. So long QT syndrome has been recognized in northern BC for over 30 years, and it's particularly common among families from the Gitxsan First Nation, which includes the town of Hazelton and surrounding communities. And in these communities, there were particularly high rates of sudden and unexplained deaths, as well as a prolonged QTC interval. So in 2004, Laura Arbour, a medical geneticist from Victoria, and her team were invited into the community to discuss long QT syndrome as a healthcare priority. And since then, they've partnered closely with the Gitxsan Nation and have performed community-based participatory research aimed at understanding and improving care for patients with long QT syndrome. And this community is now closely connected with the BC Inherited Arrhythmias program, with the program holding specific outreach clinics regularly at Rynch Memorial Hospital in Hazelton. And just to give some background on who the Gitxsan are before we get into the medical stuff. So the word Gitxsan means people of the River of Mist. Their traditional territory spans 33,000 square kilometers in northwestern BC and is divided into territories called Lax-Yips that are governed by Wilps, each with their own hereditary chief. And the Gitxsan have an intimate connection to the land, and salmon are central to their livelihood. So through careful pedigree analysis and genetic testing, multiple causative genetic variants have been identified in the community, including 2 variants in KCNQ1, which is a potassium channel, and 1 variant in ANC2. And in total, about 1 in 125 Gitxsan are affected with long QT syndrome, compared to 1 in 2,000 in the general population. So you can imagine if you had a First Nations patient presenting to hospital with syncope, for example, how important it would be to ask what nation they belong to. So why is there such a high rate of long QT syndrome in the Gitxsan? Well, it's something called the founder effect, which some people may have heard of. And the founder effect is defined as the reduction in genetic variation that results when a small subset of a large population is used to establish a new colony. And the new population may be very different from the original population, both in terms of its genotypes and phenotypes. And through the founder effect, certain genotypes or phenotypes can be emphasized or de-emphasized. So you can imagine that in some of these remote, isolated Indigenous communities around Canada, the founder effect can certainly come into play, resulting in the enhancement of unique, distinct genetic makeups in different communities that certainly can contribute to their health. And while there are limited studies exploring genetic factors contributing to cardiovascular disease and cardiac risk factors in Indigenous patients, the existing evidence suggests that different communities have distinct genotypic characteristics that likely influence rates of heart disease. In this review article published in CJC in 2015 by Laura Arbour's group, they've outlined a number of genetic factors in a variety of Indigenous communities worldwide that contribute to cardiovascular disease. And this isn't going to be the focus of my talk, but I'd just like to point out that different communities have been found to have different genetic variants that contribute to hypertension, obesity and metabolic syndrome, dyslipidemias, atherosclerotic disease, and arrhythmia. And it's also important to recognize that each nation has distinct cultural and geographic factors that may further interact with these distinct genetic differences. So, is being Indigenous a risk factor for cardiovascular disease? Well, there are certainly higher rates of cardiovascular disease in Indigenous compared to non-Indigenous Canadians. For example, in the Study for Health Assessment and Risk Evaluation in Aboriginal Peoples, or SHARE AP, they recruited 301 Indigenous people from 6 nations reserve and 326 Canadians of European descent and assessed their cardiovascular profiles cross-sectionally. And they found significantly higher rates of coronary artery disease, MI or revascularization, and stroke among the First Nations cohort. They also found significantly higher rates of cardiovascular risk factors, including dyslipidemia, hypertension, diabetes, smoking, and obesity. And census data from the 2000s also demonstrates higher rates of cardiovascular mortality in First Nations Canadians, as demonstrated by the bars in this graph. And in this graph, age groups are on the y-axis and rate ratios on the x-axis, with the light gray bars comparing First Nations women to non-Indigenous women, and the dark gray bars comparing First Nations men to non-Indigenous men. And you can see the disproportionate rates of cardiovascular mortality in both sexes, with the disparities being even more prominent in First Nations women and in younger First Nations patients. This study from the 2000s demonstrates a similar trend showing higher rates of cardiovascular disease in First Nations Canadians, as demonstrated by the dark bars in this graph. However, if we look at data from the 1980s, we see that Indigenous people historically have actually had lower rates of cardiovascular disease. And this trend has been reproduced in multiple studies. In this graphic, the black circles represent First Nations communities, the black triangles represent Northern Ontario communities, and the white squares represent all of Ontario. And you can see that ischemic heart disease admissions in First Nations people only started to surpass non-Indigenous people in the late 1980s. And they also demonstrated a similar trend in acute MI admissions, with rates of First Nations communities surpassing other Canadian communities also in the late 1980s. So indigeneity in and of itself is not a risk factor for cardiovascular disease, but being subjected to a colonial history is a risk factor for cardiovascular disease. And I think this is a really important distinction to make. This is a picture of my reserve on the Okanagan Lake. Some of you may have visited here, and I'm proud to call these lands my own. Now, I want you to picture a time before Canada's colonization. In my nation, the Syilx Okanagan Nation, our traditional lifestyle would be viewed as a very healthy one under today's cardiovascular standards. My ancestors lived off the land with a diet consisting of fish from the Okanagan Lake, berries, roots, and wild game. This required an active lifestyle of fishing, hunting, and gathering. Our chiefs were selected in a merit-based system as leaders of the community. We had our own traditional medicines and healing practices. Cultural practices, including sweat lodges and powwows, were important. Tobacco was used in ceremony, but not for habitual use. And there were no other addictive substances in our communities. Now think about how European colonization affected this rich culture and healthy lifestyle. First, Indigenous people were stripped of their lands, which is their livelihood. They no longer had access to the lakes and the forests that provided them with their traditional healthy food sources. Then the introduction of diseases such as smallpox wiped out up to 20 million Indigenous people in North America. And this includes loss of leaders, disruption of families, and devastation for communities. Then governmental policies excluded Indigenous people from the dominant economy. They were not allowed to vote, to get an education, or to enter the workforce in an equitable way. Additionally, many cultural practices were made illegal. So now you have an entire population that's been decimated by disease, who are stripped of their culture and access to their traditional food sources, and are then not allowed the opportunity to make a living or participate in the society that's been forced upon them. So then poverty ensues, and the only food you can afford is calorie dense and nutrient poor, increasing rates of obesity, hypertension, dyslipidemia, and diabetes. And in addition to this, you have institutions like residential schools that were created to assimilate Indigenous peoples. And these schools traumatize generations of Indigenous people with high rates of physical, sexual, verbal, and emotional abuse and cultural destruction. On a healthcare level, segregated Indian hospitals were instituted, and they were often understaffed and underfunded. Indigenous people were often sent to these hospitals without knowing why, and could be kept there for years at a time for tuberculosis isolation. And this was not the practice at the time for white patients, but it was assumed that Indians could not look after themselves. There are reports of harmful and unethical experimental treatments at these hospitals as well, and distrust of the medical system continues to this day as a result. In order to cope with this systematically devised trauma, rates of substance use and mental health conditions increase, and this results in a perpetual cycle of intergenerational trauma. And part of the reason I think we see this inflection point in the 1980s, where rates of cardiovascular disease in Indigenous people surpass non-Indigenous people, is due to the coming of age of an entire generation of residential school survivors. So you can see how through Canada's colonial history, assimilationist policies, loss of land and natural resources, and exclusion from the dominant economy have disrupted Indigenous people's traditional healthy way of life. And this results in intergenerational trauma, poverty, food insecurity, low education, homelessness, and structural racism. And these upstream risk factors in turn lead to our traditional cardiac risk factors such as diabetes, hypertension, smoking, dyslipidemia, and obesity. So we know that Indigenous patients now have higher rates of cardiovascular disease, but how are we actually doing with their care? Well, there are certainly inequities. So after admission for acute MI, First Nations patients are less likely to undergo coronary angiography. This is population-based data looking at 46,000 Albertans diagnosed with acute MI, stratified by First Nations versus non-First Nations. And you can see that 1 day, 1 month, and 1 year post-MI, rates of angiography are about 20 to 30% lower in First Nations patients. And this is even after adjusting for age, sex, and comorbidities. And while some might try to argue that this disparity is caused by geographic factors, these data were also adjusted for distance to the closest PCI center. And for those who do get angiography, First Nations patients have increased long-term mortality as well. So this data from Alberta shows that after angiography, patients treated medically or with PCI had increased mortality. In Manitoba, after angiography for MI, First Nations patients have increased cardiovascular mortality, as well as increased all-cause hospitalizations, including increased hospitalizations for heart failure and ischemic heart disease. But what's equally striking, and perhaps part of the cause for those worse outcomes, is this. After MI, First Nations patients have less visits to a cardiologist, less visits to an internist, and less visits to a family physician. And again, this is after adjusting for age, sex, location of residence, and socioeconomic status. So this is an example of how our system is failing. This data, also from Manitoba, looked at 12,000 patients undergoing cardiac surgery between 1995 and 2007. And the authors demonstrate that Indigenous patients, demonstrated by the blue line, had a 35% lower rate of CABG compared to non-Indigenous patients. They also found that Indigenous patients had lower rates of cardiac surgery in general. Now, you might consider that this could be due to geographic constraints and access to healthcare for Indigenous patients living in rural and remote areas of Manitoba. But when they stratified their data by geographic region, they actually found the racial disparity greatest in the urban setting, seen on the left. This data suggests that there are other racial factors beyond just geography that contributed to these disproportionate rates of cardiac surgery. And we see a similar trend in heart failure care. In this study from Alberta, we can see that prior to an index heart failure hospitalization, Indigenous patients had more all-cause hospitalizations and emergency department visits. And I mean, really, you'd hope that these touch points with the healthcare system would allow for earlier recognition and treatment of heart failure to prevent subsequent heart failure hospitalizations. And in contrast, prior to heart failure hospitalization, white patients are more connected to outpatient heart failure specific care. And after an index heart failure hospitalization, Indigenous patients were found to have more subsequent heart failure hospitalizations and heart failure related emergency department visits. However, they continued to have less heart failure related outpatient follow-up as well. And with that in mind, it's probably not all that surprising that Indigenous patients have increased adjusted mortality after a heart failure hospitalization, with this effect seen 1, 3, and 5 years after an index hospitalization. There's limited data on atrial fibrillation in Indigenous communities. In Ontario, epidemiologic data suggests that the incidence of AFib is 1.7 times higher in the Métis. And beyond that, the 1-year mortality for Métis patients diagnosed with AFib is 3.3 times higher than in age and sex-adjusted non-Indigenous counterparts. I also wanted to briefly touch on rheumatic heart disease, which is often forgotten in Canada, but it's a major cause of cardiovascular morbidity and mortality worldwide. We often associate rheumatic heart disease with our patients who've migrated from less developed countries, but we can't forget that some of our Indigenous communities have a human development index similar to developing nations. And in Canada, Indigenous children are 10 to 75 times more likely to develop group A strep infections, predisposing them to rheumatic heart disease. And this is a preventable cause of significant morbidities and mortality. So what all these studies demonstrate is our system is not meeting the needs of Indigenous patients. We know that this is a high-risk group of patients with worse cardiovascular outcomes, but we as a system are not providing equitable cardiovascular care compared to non-Indigenous patients. Of course, some of these inequities are due to intergenerational trauma, distrust of the medical system, and cultural differences. And it may seem daunting to tackle these complex issues, but we as a system are failing to provide adequate care to improve these outcomes. And it is our responsibility to work with Indigenous communities to create a system that works. And in order to meet the health needs of Indigenous patients, the healthcare system needs to adapt from a purely biomedical approach and consider in parallel the importance of Indigenous ways of knowing, being, and healing. And this is where cultural humility is paramount, to be open and willing to listen, learn, and collaborate. So through a two-eyed seeing approach, we bring together the best of two different ways of knowing, with one eye seeing the best of Indigenous knowledge and the other seeing the best of Western knowledge. The Indigenous eye is more experiential, narrative, relational, and holistic, and focuses on Indigenous strength and resilience. The biomedical eye is more objective, analytical, body-based, and focuses on epidemiology, risk factors, and treatment. And this change in approach may require a major shift for some people. But there have been multiple Indigenous communities across the country that have partnered with culturally responsive Indigenous and non-Indigenous researchers to improve our understanding of cardiovascular health in Indigenous peoples. The Canadian Alliance for Healthy Hearts and Minds is one example of this. This alliance is led by Sonia Anand from McMaster and Matthias Friedrich from McGill. And it's a prospective multi-ethnic cohort study with an aim of understanding how contextual factors affect traditional cardiovascular risk factors and outcomes. It was initiated in 2013 and includes 9,700 participants. And some of the contextual factors they are exploring include societal structure, built environment, nutrition environment, tobacco environment, access to and quality of health services. The Alliance has specifically made Indigenous health a priority, and they actually have a specific First Nations cohort. Dr. Anand's group has established partnerships with 8 First Nations communities across Canada to specifically explore how these contextual factors affect rates of heart disease in Indigenous Canadians. And they really have embraced a two-eyed seeing approach to their research. Some of the objectives of the First Nations cohort are to determine the frequency of risk factors for cardiovascular disease and cancer, to characterize the availability and access to primary care screening and management of chronic diseases and their risk factors, to determine the burden of subclinical cerebrovascular and cardiac disease, to characterize the contextual factor profile of each community and understand its association with cardiovascular risk factors. So the investigators approached 9 reserve-based First Nations communities across the country to introduce the study's goals to determine whether they aligned with the community's goals. And 8 of the communities decided to partner with the Alliance. 2 of these communities are in Alberta, in Fort McKay and Fort McKay and Musqueam. Local and national advisory boards were formed that are composed of community members and Indigenous stakeholders. These advisory boards oversee all aspects of the study. They carried out questionnaires and physical assessments and linked their cohort data to healthcare administrative databases. Biospecimens were collected and securely stored. The specimens are owned by the communities themselves, upholding the important concept of biospecimen and data sovereignty for Indigenous communities. They also brought a mobile MRI scanner to the communities for all participants, which includes cardiac, brain, and abdominal MRIs. They then assessed the communities themselves for contextual factors that could impact cardiovascular health. In one study produced from this cohort, they decided to compare First Nations communities to each other. And the reason they did this is that comparing Indigenous to non-Indigenous people can pathologize and stigmatize Indigenous people's experiences. And beyond that, it's already clear that Indigenous Canadians have worse cardiovascular outcomes. So they sought to understand why one community might fare better than another. So they compared the 8 First Nations communities to one another to look for protective factors within each community that were associated with improved cardiovascular outcomes. And I like how they emphasize a positive lens with protective factors when they could easily do the opposite with risk factors, which we're more used to in the biomedical world. So this study collected cross-sectional data from over 1,300 participants across these 8 communities. And they evaluated their inter-heart risk score, which is a well-validated predictor of cardiac risk, morbidity, and mortality. And between communities, they found a number of protective factors which reduced the inter-heart risk score, including higher socioeconomic status, higher levels of community trust, higher education levels, and close connection with family. Factors associated with a higher score included difficulty getting routine healthcare and inability to afford prescription medications. I should also note that more than 85% of all participants had a moderate to high score. They also nicely lay out distal, intermediate, and proximal factors that impact cardiac disease. So they note distal factors associated with cardiovascular disease include colonization and racism, then intermediate factors, difficulty accessing routine healthcare, and proximal factors, including the need for prescription medications, as well as the inability to afford medications. Conversely, distal protective factors include self-government and self-determination. Intermediate factors include trust between neighbors, higher income and higher employment rates, and proximal factors include increased social supports and educational opportunities. So while these results are important, some of these factors seem quite challenging to address as an individual clinician. And unfortunately, there's really a paucity of research exploring interventions to improve cardiovascular outcomes in Indigenous patients and communities. However, there are a few groups in Canada that are pioneering collaborative cardiovascular research in Indigenous communities. For example, this is a novel study by Sonia Anand's group in McMaster that prospectively investigated a novel dietary intervention. And what they did is they had 22 participants from 6 nations who underwent a 3-month control diet followed by a 3-month intervention period of a traditional Haudenosaunee diet, which was developed by community members to reflect traditional practices. Participants were encouraged to follow this traditional diet and were provided baskets of food every 2 weeks. The traditional diet was divided into 5 categories: from the woods, venison, walnuts, and maple syrup; from the water, rainbow trout, yellow perch, pike, and wild rice; from the skies, including duck, turkey, and eggs; from the garden, including white corn, kidney beans, and varieties of squash; from the meadow, including blackberries, blueberries, honey, and sunroot. It actually sounds really good. And they found that patients who followed this diet had significant reduction in body weight, waist circumference, and BMI, as well as a non-significant trend towards a reduction in hemoglobin A1C and a reduction in MRI-detected hepatic fat fraction. And the reason I'm showing this study is not necessarily just to show that traditional Indigenous practices may have cardiovascular benefits for Indigenous patients, but the real reason I like this study is that it shows the power of community partnership and collaboration in research, which can really identify these novel interventions and approaches to care. This is the kind of community collaboration, that two-eyed seeing approach, that's really required both in research and in clinical medicine to improve cardiac care and outcomes. I know it might seem daunting for an individual clinician to make a difference in some of these complex structural and societal issues. So I'd like to switch gears a little bit to provide some practical advice on how to better engage with Indigenous patients using a culturally humble approach. First, this may seem basic, but make sure you introduce yourself as well as where you're from before beginning the interaction. Sit down, take your time, and maybe take off your suit jacket. Then, before getting into the medical stuff, ask the same of your patient, including what nation they belong to. This can make a huge difference for some Indigenous patients and shows that you care. Invite family members or other patient supports to join the visit. Remember that some Indigenous patients have had negative experiences with doctors, hospitals, and authority figures, and they may need extra supports to feel comfortable. You can also ask your MOAs to invite family members routinely when scheduling visits. Make sure you give your patients ample time to share their stories and try to understand what's important to them. And allow for multiple visits to build rapport and devise mutually agreed upon goals. For some patients, maybe it doesn't make sense to start 4 new medications on the first visit, but over time, as you build trust, you can get there together. And I don't want this to be mistaken as a recommendation to undertreat Indigenous patients. We should still offer all of our medical recommendations to Indigenous patients that we would to any other patient. But we need to recognize that some Indigenous patients may have priorities that supersede the ezetimibe, and that's okay. Sometimes just having a positive, culturally safe interaction, regardless of which medications were started that day, will go further in a patient's care, as they'll be more likely to have that trust moving forward and engage in care over the long term. It's also important to understand that there are unique customs in verbal and nonverbal communication in some Indigenous communities. For example, in some communities, avoiding eye contact is a sign of respect. When my dad worked in the north to support Inuit residential school survivors, he learned that in some Inuit communities, raising your eyebrows means yes and squinting means no. And it's also important to recognize that language barriers may exist and interpreters may be required, especially in our elder Indigenous patients. Here are some other strategies to close the gap. Know the traditional territory on which you live and practice, and beyond that, reflect on how those lands have impacted your life in a positive way and how you can respect and protect those lands as well. Take a course in cultural humility. And even for me, every time I take an Indigenous cultural humility course, I learn something. Train Indigenous healthcare workers and researchers who are more likely to give back to their communities and inspire future generations. Reflect on your clinical practice. Can you provide more equitable care? Maybe this means scheduling an extra 15 minutes for an appointment with an Indigenous patient, or maybe it means expanding your practice to include outreach, or maybe it means making an extra phone call when an Indigenous patient is lost to follow-up. Commit to long-term collaborative research partnerships with Indigenous communities. And the key here is partnership. So that means including communities in every step of the research process and answering research questions that will benefit the community. And try to include Indigenous researchers on projects associated with Indigenous communities as well. And review the healthcare-related calls to action from the Truth and Reconciliation Commission of Canada, which are calls to action number 18 to 24 and 55. I'd like to review these now and provide some approaches to address them. Number 18, acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies, including residential schools, and recognize and implement the healthcare rights of Aboriginal people as identified in international law, constitutional law, and under the treaties. So to address this as healthcare providers, we need to recognize the upstream factors contributing to current disparities in cardiovascular morbidity and mortality between Indigenous and non-Indigenous Canadians, including the impacts of residential schools, Indian hospitals, racism in the healthcare system, and other impacts of colonialism. Number 19, in consultation with Aboriginal peoples, establish measurable goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and publish annual progress reports and assess long-term trends. Such efforts would focus on indicators such as life expectancy, chronic diseases, illness incidence, and the availability of appropriate health services. Number 55, provide annual reports or any current data requested by the National Council for Reconciliation so that it can report on the progress towards reconciliation. And particularly progress on closing gaps between Aboriginal and non-Aboriginal communities in health indicators such as life expectancy, chronic diseases, illness incidence, and the availability of appropriate health services. And a proposed response is to engage in collaborative cardiovascular research through partnerships with Indigenous communities, exploring not only retrospective epidemiological data, but also investigating the impacts of therapeutic and public health initiatives. Research questions should be deemed relevant and important to the communities involved. Number 20, in order to address the jurisdictional disputes concerning Aboriginal people who do not reside on reserves, recognize, respect, and address the distinct health needs of the Métis, Inuit, and off-service Aboriginal and off-reserve Aboriginal peoples. And so we need to ensure data is disaggregated and stratified into distinct groups, including First Nations, Métis, and Inuit peoples who live both on and off reserves. Number 21, provide sustainable funding for Aboriginal healing centers to address the physical, mental, emotional, and spiritual harms caused by residential schools, and ensure the funding of healing centers in Nunavut and the Northwest Territories is a priority. Number 22, recognize the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders where requested by Aboriginal patients. And so we need to recognize and embrace a two-eyed seeing approach and understand the importance of traditional healing practices to Indigenous patients' health and wellness, including healing circles, sweat lodges, smudging, and medicine pouches. Number 23, we call upon all levels of government to increase the number of Aboriginal professionals working in the healthcare field, ensure the retention of Aboriginal healthcare providers in Aboriginal communities, and provide cultural competency training for all healthcare professionals. And we need to commit to training Indigenous people in healthcare, leadership, and research positions. And we must ensure that all healthcare professionals and researchers undergo cultural humility training. Number 24, we call upon medical and nursing schools in Canada to require all students to take a course dealing with Aboriginal health issues, including the history and legacy of residential schools, the United Nations Declaration on the Rights of Indigenous Peoples, or UNDRIP, treaties and Aboriginal rights, and Indigenous teachings and practices. This will require skills-based training in intercultural competency, conflict resolution, human rights, and anti-racism. And we need to incorporate Indigenous curricula into training programs for healthcare professionals, including continuing medical education initiatives. So in conclusion, Indigenous Canadians have higher rates of cardiovascular disease, but indigeneity is not inherently a risk factor. Upstream risk factors play a major role in Indigenous heart health. Inequities in cardiac care exist in Canada, and through partnerships with Indigenous communities, we can close the gap. Lim Limped, thank you, and happy to answer any questions.
Thank you, Miles. That was amazing. Cultural humility, I think that really is the key. And, I think one of your last points there in terms of inequities in cardiovascular health, obviously we would expand it and across the entire spectrum. We have future rounds, I think sometime in June, that Dr. Geeta Sharma, who is a local PhD scientist here who's been doing a lot of work in the North, is going to be presenting on similar data in other areas. So thank you so much. There are quite a few questions. So I will start off with Dr. Daniels. He is asking that some are advocating for removing ethnicity from our case summaries and exam question stems as they perpetuate bias. I like how you reframed a case summary, but in a short stem in an exam question, including the ethnicity can send a negative message linking that ethnicity always with whatever condition you are testing on the exam. What are your thoughts on this?
Yeah, I think that's a good question. I think it probably depends on the exact question. Like, I do think that as healthcare providers, understanding the epidemiology of different diseases is important. And so recognizing that certain ethnicities may have higher rates of different diseases, it may be relevant in some questions. But, I think definitely if you're talking about substance use, I think it's not relevant to include the patient as First Nations. Like, I don't think that that's going to benefit anyone's learning. But I think if the ethnicity itself is relevant for some reason for the given health condition, I do think it would be reasonable to include that in an exam type STEM. But I think it's important. I think it's great that you're sort of recognizing that as a potential issue that could perpetuate bias. And I think that that's really one of the major steps in sort of cultural humility is really recognizing where these issues can arise, and then trying to frame them in a way that actually makes sense. And if it's going to benefit the learners for whatever reason, then I think it's reasonable, but it's important to be mindful, I think, is the key.
Yeah, of why you're using it.
Yeah.
So Dr. Duran Moreau is an occupational health specialist, and he asks, well, thanks for the excellent presentation. He's asking how long working hours, 55 plus hours per week, are assessed as a cardiovascular risk factor. It increases the risk of death from MI by 17%. Statistics show that Indigenous people have a higher number of weekly hours of work than non-Indigenous related to lower hourly wages. So it's very possible that weekly work hours play a role in the CV risk for Indigenous people. Any thoughts on that, or has that been looked at?
Not that I'm aware of, but I think that's an excellent point. And I think, enriching our communities with education and good paying jobs that allow you to afford better medications, have a higher health literacy, travel more easily to access healthcare. All of those things I would be sure would play a role in the reason that we see some of these disparities. So that's a really good point.
Thanks, Miles. We have a question in the room. Adrian?
Thanks very much, Dr. Marchand. Some of the data you showed were now getting on for 10 years old. I think really useful. Yeah. What's being done to update those? It would be nice to see some change, wouldn't it? And it's good to what? It's the why that's the important thing, obviously.
Yeah, no, I agree that, a lot of the most recent sort of studies and data that are available are sort of from around 2014, 2016, which is now getting, up close to 10 years ago. So there's not, there's not as much data like from beyond 2020, but a lot of the new CIHR grants that are being funded, they require that the research that's being performed actually includes Indigenous communities. So I hope that, you know, in the coming 2 to 5 years, a lot of the results of that actually provide us with an update on what the actual evidence is. I'm part of the Canadian Heart Function Alliance, which was a large CIHR funded grant, and one of the sort of 4 prongs of the alliance is Indigenous health, and the other is one of the others is democratization of care. So all of these studies that are going to be produced from this alliance need to have some sort of Indigenous health lens as well. So, and a lot of these new CIHR grants have the same. So I hope that we're going to start seeing an abundance of more evidence. But there, yeah, you're right. A lot of the most recent evidence is actually 10 years ago evidence. So.
There's another question online. Actually, it's really interesting. Dr. Houston says, you mentioned the critical issue of using an interpreter when necessary. We have actually done a small study here locally where we now have those digital interpreters that you know, you can carry around and take various places. But he says, last I checked, Cree, the most common Indigenous language in Northern Alberta, was not available on Language Line, which does provide a wide range of languages such as Amharic and Tigrinya. I can. Maybe an opportunity for improvement. Are you aware of any resources there?
You know, of course the predominant languages vary province by province and nation by nation. So Cree would not be one of the sort of predominant languages in BC, but I think that that's probably something worth looking into. Unfortunately, a lot of these you know, Indigenous languages are not people's first languages in a lot of instances, except for in the older generations. But I do think there is some resurgence of Indigenous languages over the past 5 or 10 years. So I do think it's probably worth looking into to see if a translator could be found for at least some of the more common languages spoken around Edmonton.
Yeah, I'd have to check if it's on our digital interpreter. I don't even know offhand. We'll look into that. So Dr. Bello is one of our nephrologists, very heavily involved in international kidney care work. Says, this is a great talk and extremely useful perspective. Thank you. The issues seem systemic with the large gaps in optimal care across most other chronic diseases such as CKD, diabetes, etc. What is the best approach to addressing these issues in a more encompassing way? How can we ensure harmony of the Western approaches to clinical practice research and cultural values or expectations in chronic disease care? You know, it kind of reminds me of the whole, I mean, you know, I always like to use the fire hose example, right? But, you know, even simple things like addressing, you know, salt in our diet. And it's such a big issue and where to start. You did such a nice job breaking it down, but I wonder if you have any thoughts about this.
Yeah, no, I think, I do think that it becomes overwhelming, I think, to try to think about how we can improve. And I think that's why I think if you can, I tried to lay out some sort of practical things. And even if as individuals, we can each focus on just even one of those things to try to be better for our Indigenous patients, I think that goes a long way if everyone commits to something like that. But at the same time, really improving Indigenous health systemically comes upstream from, I think, what we actually are able to accomplish as clinicians and researchers. So that comes down to housing, clean water, access to healthy food sources, self-government, self-determination. All of those things are these upstream risk factors. And by the time that we're seeing a lot of these patients, those things can't actually be fixed, but I can't be fixed by us in the office, right? But I do think that systems wise, there are big opportunities to make differences in these ways. And I think the key is collaborating with the communities and working together. And some of these research groups like the Canadian Alliance for Healthy Hearts and Minds have really demonstrated a framework on how to do that, with advisory boards that include community members and stakeholders at the local level, at the national level. And there is more infrastructure now that's actually being created from a research perspective. For example, I'm one of the board members on IPERC, which is the Indigenous Physicians Engagement Research Council. And that was actually formed as a part of the funding for the Canadian Heart Function Alliance. But the hope is that IPERC will serve as sort of a pillar for research across Canada, extending outside of the Heart Function Alliance, to help researchers engage with communities and overcome some of the challenges that come with performing research in communities that have a history of this intergenerational trauma. So I do think that there is some infrastructure that's being developed that will help us move forward with some of these issues. Hopefully that answers the question somewhat.
Oh, yeah, no, absolutely. And also, right, educating ourselves, which is what hopefully this rounds was meant to serve. So on behalf of the University of Alberta Department of Medicine, thank you so much, Miles. You're doing amazing work. And, you know, this was a really outstanding opportunity for us to get to hear, you know, your work and the things you're doing. And I look forward to seeing more to come. So thank you so much.
Thanks a lot for having me.
Okay, take care.
Good Friday, everyone.